All right, I see that many people have already joined, so we are ready to start our webinar. Hello, everyone, and welcome to CDEP's Global Health Conversation Series. Thank you for joining us. In today's webinar, we will discuss the issue of access to medical oxygen, an issue that has only been exacerbated from the ongoing COVID-19 pandemic. For today's discussion, we have collaborated with the Every Breath Counts Coalition and Oxygen for India. And we are very honored to have with us Leith Greenslade, coordinator of Every Breath Counts Coalition, Dr. Ayobami Bakare, a community health physician from University College Hospital Ibadan in Nigeria, and the Karolinska Institute in Sweden. We also have CDEP's director and co-founder of Oxygen for India, Dr. Ramanan Laxminarayan. We have some specific questions for the speakers, which they will address in the first part of the webinar. And we will have some time towards the end of the hour to address any of your questions. So please feel free to enter them in the Q&A section of the Zoom app. Before we start the discussion today, Dr. Laxminarayan, director of CDEP, will give a brief introduction to the topic we're discussing today. So over to you, Ramanan. Thank you.
Thank you, Erta, and pleasure to see all of you. This has been a great continuing series, and many of you have come back for more of the webinars, and it's great to see all of you again. So oxygen is typically not a problem that CDEP has worked on, except for the last year, when in the middle of a crisis, when things were really bad in India, our teams got together to figure out how to solve the problem of oxygen shortages in India, which are very acute during the second wave. And there were many deaths due to COVID, which is a subject of our research, but not as much attention to oxygen, which was kind of surprising given that it's such an essential commodity that's required at all times. But we do work on pneumonia, we work on respiratory disorders, but we've never really focused on oxygen as really being a major issue. And I think COVID really brought home for many of us, especially in India, but around the world, how important oxygen really is, even during non-COVID times. Now, of course, CDEP was part of a much larger effort called Oxygen for India, which had raised a lot of money internationally from about 12,000 people who contributed to help bring oxygen assets to India. And this was part of multiple initiatives that were held at the same time. But we then built on top of what we did during the COVID outbreak in India, the second wave, to be able to create what we are calling a national oxygen grid, something we'll spend some time talking about when we get into the panel discussion. But I think for all countries that have faced oxygen problems during COVID, the questions in front of us are, is this something that is an ongoing problem? To what extent is oxygen available even during normal times when the deaths are invisible and people suffering is invisible, whether it's from trauma or from being pregnant without oxygen in case of a significantly difficult situation, in the case of children with pneumonia, and how much attention do we really pay to the normal suffering from lack of oxygen and during non-COVID times? And then the third question is really on how we can use the opportunity provided by COVID in terms of the attention on oxygen to be able to solve the problem for the longer term. So I think these are sort of the themes that we wanted to discuss. And I think these are of relevance not just to India, not just to Africa, but many countries around the world. In fact, oxygen shortages have been felt in Italy. They were faced in the UK. They were faced in New York as well, as a matter of fact. So this has not been a single country issue, although the degree of challenge has been much greater in some countries compared to others. And we really owe it to the people who died from COVID because of oxygen shortages to make sure that we are able to fix the problem for the longer term. And that's what we're committed to doing at CDEP. And we look forward to these conversations and more around the specific oxygen issue to figure out how we might want to do that. So thanks, Erta, and back to you.
All right, thank you, Ramanan, for that introduction. We will start with our first speaker, Leith Greenslade, coordinator at Every Breath Counts Coalition. So good morning, Leith, and thank you for joining us today. So the issue, as Ramanan just mentioned, the issue of oxygen supply during the COVID-19 crisis is actually a broader issue of lack of routine access to oxygen for respiratory care. Can you speak more about where these shortages are and why do they occur?
So thanks, Erta, and thanks, Ramanan. I want to share my screen and show a few images as I answer your question. So the image you can see continues to haunt me. This is an image that was taken in Peru in February this year at the height of what was Peru's, not their first, but their second oxygen crisis. And the long line of green cylinders that you see empty, waiting to be filled. And the people waiting for them, one of them is sleeping overnight, you can see they're waiting, are waiting for oxygen to take home or to take to a hospital to treat a loved one. And we saw images, we continue to see images of these kinds of scenes from the pandemic. Now, you don't get to a situation where someone is that desperate and that alone without decades of underinvestment in oxygen as an essential medicine. So prior to COVID, oxygen was not a medical commodity that governments were focused on, particularly governments in low and middle income countries. Neither was it an issue that had much support from the global health community. The multilateral health and development agencies also were not focusing on oxygen. So when COVID hit with the massive quantities of oxygen required by COVID patients, this was a disaster waiting to happen. And that's why we've seen continually now since summer last year, in every region of the world, images like this, and the suffering and the deaths that have resulted from lack of access to oxygen are tragic and must never be allowed to happen again. So the Every Breath Counts Coalition has been monitoring the oxygen crisis since we worked on what we call the Oxygen Needs Tracker with international NGOs PATH and the Clinton Health Access Initiative. We launched this in November last year, and every week we've been publishing what we call the Oxygen Crisis Risk Map. Every country with a dot on it is either experiencing or at risk of oxygen shortages. The countries in red, we call them code red, are facing what we call hockey stick increases. So the curve goes up like a hockey stick in terms of their daily oxygen need for COVID patients. These are the countries where we're seeing deaths. Now it changes because if we were looking at this map in May, April, as Ramanan well knows, it would have been India and Nepal driving oxygen need, but the virus moves quickly and leaves oxygen shortages in its wake. But at this point in time, these are the countries that are facing deaths, elevated COVID deaths from lack of access to oxygen. I just want to pull out some of this is the hockey stick curve I mentioned before. This is some of those countries on that map, but it shows you their 3-month increase in oxygen need. So you can see this is just 3 months, and look at Russia. It was fairly stable until about a month ago, and then it takes off. It moves so quickly that the health systems are inundated with patients needing oxygen and they can't respond. And we saw that play out in India and then Nepal with tragic, tragic consequences. But other countries are experiencing similar surges, although not at the scale of India because of India's population. So we need to keep our eyes on all of these countries. These are the countries that need support, national, regional, and international, or we will see oxygen-related deaths. This picture is just a reminder before I conclude this question. COVID is just the tip of the iceberg for oxygen need. And the pandemic has revealed to us what has always been a problem, is the underlying needs of patients with hypoxemia for oxygen. Lots of children with pneumonia, lots of neonates, and lots of adults as well with conditions, not just infectious, but COPD and chronic conditions. We have this massive underlying need for oxygen, which is why we have to deal with it during the pandemic. But the investments we put in place now, if done correctly, can serve this hidden need and save many, many, many lives over the next decade, only if we get the investments right. Let me stop there.
Thank you, Leith. That was very moving. I would say the opening image. I think it's going to continue to haunt many of us. So when it comes to addressing this issue, how well has the private sector performed in solving the problem of oxygen supply? And is there a role for governments to step in and provide access in places where it's currently lacking?
Yes, there's a huge role for governments, but not only governments. So like any area of COVID or any area of public health, you need governments working with industry, working with non-government organizations. The United Nations is critical. So there's a network of actors that need to come together. Now, this is what we didn't have with oxygen. So we did have it with vaccines, and we had vaccines developed early by industry with government investment. And so we had that. We had a network of relationships going into the pandemic with the pharmaceutical industry and public health leaders that we didn't have with oxygen. To put it bluntly, the leaders of our global health agencies and many governments just didn't know who the people were running oxygen in industry. They couldn't pick up the phone or send an email to the head of some of the big medical gas companies or the big oxygen concentrator companies. We didn't have those relationships. So we had to scramble to build them. Now, it's still not a perfect situation. There's much more work to be done to bring industry to work in full partnership with public health when it comes to oxygen. But the oxygen industry now understands it is part of the public health infrastructure. This has been the big leap forward that we've been able to make. They understand that there probably will be more respiratory pandemics. COVID is not going to be the last, and it may not be the worst. And they need to be in constant partnership with public health. Now, to the industry's credit, they have actually stepped up. So Air Liquide, one of the major medical gas companies, they have reported to us just a few weeks ago that between 2020 and 2021, the amount of oxygen they were delivering for an emergency went from 400 tons in 2020, and wait for this number, to 9,400 tons a year later. So they have the capacity. This is not a technology we have to develop. We have it. They have the capacity to supply the oxygen. What's missing are the government partnerships, the logistics, all the infrastructure that goes around transferring that from an industrial environment to a medical environment. This is where we failed tragically, and Ramanan knows better than most, because India was India's big challenge to move the oxygen from industry to the medical system. And this is what we have to learn from and get right next time. I'm positive about our potential to work with industry on oxygen, very positive.
Thank you. Thank you, Leith. We are now going to move on to our second speaker, and that's Dr. Ayobami Bakare. Thank you for joining us. Dr. Bakare, if you could unmute and join us. Yes, there you are. Dr. Bakare, you're still on mute. Maybe there's a network delay.
Hello?
Oh, okay, great. Yes.
Can you hear me?
Yeah, we can hear you very well. I'm assuming that Dr. Bakare is experiencing some network issues. Can you hear us now?
Yeah, I can hear you. I can hear you.
Okay, great. So thank you so much for joining us. And for you, prior to the pandemic, you co-authored some of the most important studies on children's access to oxygen in hospitals across Nigeria. What did you learn about access to oxygen before the pandemic? And do you think that you could generalize your findings across hospitals in Africa?
Okay, thank you, Ita. So prior to the pandemic, our team, we learned 5 big lessons, which I'm going to go through one by one regarding oxygen access to children in Nigeria. The first one is that the access to oxygen is poor, and there are several reasons. No hospitalized children have their pulse oximetry or their blood level checked routinely, and about 1 out of 5 children with low oxygen blood level receive oxygen therapy. And another thing surprising is that among those who are actually given oxygen, about 2/3 did not require oxygen. So you could see a kind of haphazard oxygen delivery for children. And these have several implications, even especially for preterms and low birth weight. And reasons for this were structural problem, lack of pulse oximeter, lack of oxygen equipment, poor infrastructures, technical problem like poor technical know-how on maintenance and repair, most biomedical engineers or technicians, they don't know whether their filters to be changed. And then accessibility to spare parts, not easy to get spare parts when procurement have been done, no negotiation for spare parts or training of site technicians for continuity and sustainability. Another that, apart from that, we also have clinical failures, or let me say lack of guidelines, lack of training on oxygen therapy, lack of training on use of oxygen concentrators and the likes. And this span through pre-service training and also in-service training, not enough training for healthcare workers. Then we also learn that presence of oxygen equipment actually does not translate to oxygen access to patients. So sometimes oxygen equipment is sitting down in the children's ward, is sitting down in the labor room, but the healthcare workers, the one way or the other, perhaps maybe due to culture, due to hospital system, the patient does not just get the needed oxygen. Rather than that, he or she gets transferred to another center, whereas oxygen equipment is available. Then we also find out that though there are many reasons for equipment failure, but in Nigerian context, we need to emphasize on poor management and not giving due accord to the biomedical technicians or engineers. Many times, these people are not considered as key players. And I still remember when one of the technicians reported that she got to know that they have oxygen concentrators when the concentrator broke down. So they are not being carried along in the procurement plan also. And that is one of the another major concern in Nigeria, leading to poor access. The biomedical technicians are not motivated. On a positive note, we found out that fine, because oxygen equipment is expensive, by providing for some hospitals with moderate access to oxygen cylinders, oxygen concentrators, with pulse oximeter, it can significantly improve how they use the oxygen. I did mention earlier that 1 out of 5 children that needed oxygen receive oxygen, and those that not even need oxygen, they were given oxygen. But we found out from our studies that if you provide pulse oximeters, healthcare workers can make the best use of the little available oxygen and ensure that it gets to those that critically need that oxygen, thus helping to increase impact of oxygen therapy. And lastly, we found out that the supply chain is inefficient, and then it is also expensive, not only to hospitals, but to patients. Patients and their situation by patient had to opt for discharge against the medical advice because they could not pay for the oxygen. And sometimes hospitals could also not keep track or keep paying the bill that have accrued from the oxygen purchase. So these are the 5 big lessons that prior to COVID that we learned from our study. And concerning your second question regarding generalization, fine. to some extent, some problems are general to, let me say, to African settings, such as the poor power, poor road networks, and inefficient supply chains. There are some couple of publications from other countries that have actually confirmed what we found out from our studies. Last year, we also published a paper with other authors from Uganda and also Kenya, trying to share lessons learned from our oxygen work on the field prior to COVID, whereby we recommended the need to support healthcare workers with training and pulse oximetry, and also the need to also ensure that biomedical technicians are given adequate support so that the existing oxygen supplies could be optimized through training, protocol, and logistics. Thank you so much. Let me stop here.
Thank you. Thank you so much, Dr. Bakare. There's very unique insights from your part, and just so important to highlight that lack of access does not always correlate with lack of availability or lack of equipment. So we move on to the next question, where we are talking we'll talk a bit about the COVID-19 pandemic. So during the pandemic, how has Nigeria been able to address these oxygen shortages and for COVID-19 patients? And do you think that the new oxygen equipment that was purchased during this period is going to address some of the shortages that were there from before that you have identified for children?
Okay, yeah, thank you for your question. So, how Nigeria have actually addressed oxygen shortages, I'll just give a slight background. And we have, prior to COVID-19, we have United for Oxygen Coalition, which is a sister coalition to Every Breath Counts. So the focus of the coalition is to ensure that no patient in Nigeria died from hypoxemia or due to lack of oxygen. So that coalition is already formed, and which is being led by the Federal Ministry of Health for coordination and through support from Clinton Health Access Initiative. So we already have that on ground. And then as part of presidential response to COVID-19, we have the Presidential Task Force, which is a kind of ad hoc committee to supervise and coordinate government-led response to COVID-19. So through these two platforms, we're able to, in a way, to ensure that we try to mitigate the oxygen shortage. And specifically, so the PTF, which is the Presidential Task Force Committee, supported the Federal Ministry of Health to ensure reactivation of dormant PSA plants in the country. So there was immediate urgent call from United for Oxygen and NGOs like Clinton Health Access Initiative did a rapid assessment. So with that support, we're able to at least reactivate the non-functional oxygen plant. And with further engagement also, the COVID-19 Presidential Task Force also released approximately $7 million for procurement and installation of 38 new oxygen PSA plants. And that is from the government side. And just like I said earlier, that we already have a platform which is being coordinated by the Federal Ministry of Health, but we have partners, we have developmental partners like Clinton Health Access Initiative, Oxygen for Life, Save the Children, World Bank, and WHO. So that platform gave opportunity for everybody to come together. I think we are having a monthly meeting to review the oxygen gap, and I'm happy to say that through that we're able to have a coordinated response to ensure that oxygen shortage did not really affect treatment. So specifically through Bill and Melinda Gates Fund, Chai was able to support the Lagos State Ministry of Health to construct and get it running a new oxygen plant at the infectious disease hospital, which serves as the main isolation center in Lagos State for COVID-19 patients. So that was done through the United for Oxygen platform. We also have donations from WHO, about over 500 oxygen concentrators were also donated to the Presidential Task Force on COVID-19. And then other members of the platform, and we also have a Live Bank, which also took upon itself to be distributing oxygen cylinders to different isolation centers across the country. Over 1,000 oxygen cylinders were actually distributed by Live Bank across the country. And based on our previous works, we have partners, or we have actors in oxygen prior to COVID-19. So Chai supported training of healthcare workers, just like we had known before that healthcare workers need to be trained. So Chai supported training of healthcare workers and BMEs, biomedical technicians and engineers, through funds from Bill and Melinda Gates, and also through funding from Unitaid. Chai was able to owned PSA plants that were not functional. Chai was able to actually supply oxygen generators for them, so that at least they were able to start producing oxygen. They also have other UN bodies like UNICEF that donated over oxygen concentrators to the National Center for Disease Control, and over 1,000 concentrators were also donated to tertiary health facilities, and also additional about 800 to secondary health facilities across the Federation. All these efforts are to ensure that increased access or availability of oxygen equipment. They also have Oxygen for Life Initiative, another NGO, who's also a partner, also as a member of the United for Oxygen platform that supported isolation centers in 2 states in Southwest Nigeria with oxygen concentrators and pulse oximetry. And then Save the Children, also through their inspiring project being funded by GSK, were able to support 2 states, Lagos State and then Jigawa State in northern Nigeria, with concentrators, and also in northern Nigeria, they're able to construct piped oxygen system in some selected secondary health facilities, just to ensure that there is increased oxygen access to COVID-19 patients. And also, I need to also highlight that Chai also did something innovative by also doing oxygen kiosk like a mobile oxygen structure at the community, such that a patient that needed oxygen prior to transfer to isolation centers, and they are not deprived of oxygen therapy. So it was just an innovative oxygen delivery method when we're at the heat of the COVID-19 pandemic in Nigeria. And just like Leith said, we also have Air Liquid, who have been supplying liquid oxygen to health facilities that have a capacity for their storage. And they have also been supporting maintenance of oxygen equipment and other accessories. And they also work to ensure that they increase their production. And ESEP also is also another private company who work tirelessly to ensure availability of plant components for installation of the new PSA plant. So these are just some of the efforts that the government and also developmental partner through the United for Oxygen through the United for Oxygen, we have put to ensure that we are able to shove off that oxygen demand. So thank you. Let me stop.
Thank you very much, Dr. Bakare. It's really impressive to hear of so many different initiatives and so much effort going into this. So thank you for sharing this with us. We'll move on now to Dr. Ramanan Laxminarayan, and this time not as director of CEDAP, but as co-founder of Oxygen for India. So Dr. Laxminarayan, in the spring of 2021, the COVID-19 pandemic in India took proportions of a humanitarian crisis, and people living only miles away from an oxygen plant still did not have access to oxygen, and they were dying from the lack of medical oxygen. So could you tell us what are the factors that contributed to this? How did it get to this point in India?
Right. Thanks, Sarita. So India, as most people know, went through a terrible second wave of COVID during March and April of this year. And the demand for oxygen went up 10 times from about 800 metric tons per day to 8,000 metric tons per day. And, even during a normal period of time, the medical oxygen demand in the country is only 10 or 15% of the overall medical oxygen demand. Most of the other oxygen is used for industrial purposes. But the medical oxygen requirement during the second wave exceeded the total oxygen production in the country. And of course, that was only one part of the problem. The second part was that even the production that was available was not available in places where patients existed, because 80% of India's oxygen production happens in only 8 states. And those states are not necessarily the ones where the demand is the greatest. And also the places in which oxygen tends to get produced for industrial uses tend to be places like steel plants, which are very far away from any sort of urban center. So India both had a supply issue as well as a distribution issue, because there is typically not the infrastructure to move that quantum of oxygen by rail or by road. And oxygen is not an easy commodity to move. You can only drive oxygen tankers at the rate of about 30 kilometers per hour. So if you can imagine that if you're about 200 kilometers away from an oxygen plant, and 200 kilometers is not that far, it still is going to take you about 7 hours to get the oxygen from one place to the other. And that's assuming that the trucking capacity actually exists. So we had a supply issue, and we also had a distribution issue. And consequently, many people died. It's estimated that millions of people died during the second wave. The estimates range anywhere from about 3 to 8 million people having died during COVID overall, but with a vast majority who died during that second wave. And I think, as the other speakers have said, we've forgotten that oxygen was the first and most important medical intervention for saving lives. And sadly, India had not learned from the experience of other countries before it that have also had oxygen shortages. Somehow this was not part of the preparedness planning at the scale that it really needed to be. But the path forward is, of course, that we're preventing oxygen through vaccination. But a major effort right now is towards that CDEP is involved in, is in pulling together a national oxygen grid. And the national oxygen grid is based on a few observable facts. The few observable facts are: one, we have oxygen in places that are different than the places where people need the oxygen. That's number one. Number two is that the volume of production is insufficient to meet the needs of medical oxygen when you consider all the uses that are required. And number three is that there could be seasonality in oxygen requirement. There could be obviously variations over time in oxygen requirement as COVID or any sort of follow-up respiratory disease could really bring upon us. And what we need is something similar to a gas grid or a electricity grid, where the production can happen in one part of the country or a few parts of the country, but it's relatively easy to move this production to other parts as they actually need it. And so with that view in mind, we're working with the government of India and a couple of state governments, Uttar Pradesh and Karnataka, to figure out how to do pilots of these kinds of oxygen grids, which will first operate at the state level and then move, on to a national level. I think that the challenges are many. One is that a grid by necessity requires transportation infrastructure. If you see the quantum of oxygen assets that have come into the country, they are actually production assets. They're not transportation assets or storage assets. So we can have any number of, pressure swing adsorption plants, or we can have oxygen concentrators or production options. But we also need storage tankers. We need to be able to move liquid oxygen from one place to the other. I think, as Leith mentioned, the biggest change that has happened because of COVID is that the oxygen manufacturers have realized that they're not just an industrial commodity producer, they are a critical part of the public health system. And governments have recognized this as well, that keeping track of medical oxygen is an essential public health function. And if we can retain that thought and make that the focus for how we plan our logistics and infrastructure going forward, then we would have had something positive emerge over really a really bad tragedy that has befallen many parts of the world in 2021. Now, the capacity to put all this together requires knowledge of logistics, of supply chain associated with refilling cylinders, replacement parts, capabilities, related to healthcare workers on using the oxygen. I think, we know that having oxygen is not sufficient if it's not actually used, and figuring out how to use it is very important. A power infrastructure is important, because if you don't have power, production becomes unreliable, and storage also can be unreliable if you're using liquid medical oxygen, storage tanks. There's certainly an issue of there needs to be sort of some sort of business model with making sure that the price of oxygen is consistent and affordable for people in different parts of the country. And then it's, of course, a huge issue of maintaining these assets, whether of PSA plants or of LMO generation plants or of storage capacity. That asset management, and particularly in remote areas, where this capacity doesn't exist right now, is really going to happen going forward. So I think a lot of work lies ahead of this community that is interested in ensuring that nobody dies because of lack of medical oxygen again. And that is a tall order, because many people do die even today because of lack of medical oxygen, even when there is not a COVID crisis. But those deaths are invisible to us because we don't necessarily attribute those to lack of medical oxygen, although that's really what is really going on here. As in the coming months, we've got a lot of work that we will be able to share in terms of, at least for India, what the architecture of such a grid would really look like. The software platforms which will provide transparency on where oxygen is available and where it needs to move to, and much more in terms of bringing in sort of the business model for how we are able to maintain these assets at a national scale in a non-profit sort of a way. I think the commercial model for oxygen works well for industrial purposes. A commercial model of oxygen which is based on a purely profit motive is probably inconsistent with a public health objective. And this is where government needs to step in and be part of a strong public-private partnership, which encourages the private sector to help solve the problem, but also keeps a lid on what the prices might look like for patients who, at the end of the day, are the ones who are mostly paying for the oxygen when they really need it. So happy to talk about this some more in terms of the national oxygen grid, but we'll turn back to you, Arta, for questions.
Yes, so you have sort of addressed my next question, but I will ask it anyway, because there are some parts of it that it would be nice to kind of to get your insight. So in India, India received a lot of support from people and organizations across the globe, and the government is now investing in oxygen to prevent a repeat of last spring's tragedy. But do you think India is doing enough in terms of these investments? And how can we make sure that these investments that are made now continue to save lives 5-10 years from now?
So in response to the oxygen crisis, both the government and private philanthropy have brought in a huge number of oxygen assets into the country. Oxygen for India itself has brought in 40,000 cylinders and 3,000 concentrators. That's just one entity which CDEP led. All put together, the estimate is something like 100,000 concentrators, probably the same number of cylinders, and about something like 2,000 PSA plants, which are capable of producing oxygen for the level of a hospital, have come into the country. But the way in which these have been deployed has been not a coordinated approach, and much more importantly, has not recognized that there is an existing infrastructure of liquid medical oxygen that already exists. And unless we are able to build on top of the existing infrastructure, we may end up just disrupting the existing infrastructure. So let me give you an example. If we are placing PSA plants in the middle of a city, which is already served by liquid medical oxygen, and typically PSA plants cost more money to operate to produce per cubic meter of oxygen than LMO plant would. Now, what we would have done there is we would have displaced an existing production, an existing set of players who are working there, but replaced it with a system that is less efficient in the hands of a hospital that is not really well equipped to manage oxygen generation. And consequently, we may end up with a situation where this PSA plant breaks down, the LMO producer is no longer supplying to that hospital, and we have a worse problem in the future. So, as I say, the road to hell is paved with good intentions, and I think a lot of good intentions in the context of COVID could end up leaving us in a worse situation than where we were, not because of lack of resources, but simply because we haven't carefully thought through what the implications are of what we do and what we disrupt when we bring in new assets. And so it's not a question of, I think doing enough is a simplistic way of looking at it. It's a question of doing the right thing. And we have to be careful to not end up in a place where we're worse off, because in our intent to do more, we actually disrupt a functioning part of a system rather than compensate for a dysfunctional part of the existing system. And that's a responsibility that we all have.
Thank you very much, Ramanan. We are now moving on to some questions from the audience. We have 2 questions so far, so please do bring them on if you do have them in the chat or the Q&A section, it doesn't matter. The first question is on new technologies. Are there any promising technologies in the pipeline? For example, improved oxygen concentrators? This question is open to all of you, so anyone can take it if you know.
So I'm happy to comment. One of the positive things when you have a lot of focused energy on a neglected area is it becomes ripe for innovation. And we do need innovation in the oxygen space. We need it from the oxygen concentrators, which are the mobile units, right through to the very expensive liquid oxygen plants and everything in the middle. So we don't have a system yet that is really suited to the needs, particularly the medical needs in low resource settings. So we know we've been supplying equipment that's not quite right. So take the oxygen concentrators. Those units have done mighty work during COVID, but they certainly were not designed for it. They were designed for the home care market in rich countries for all the chronic disease patients, but they've been repurposed during COVID and they've done mighty work, but they're not where they need to be. So yes, there's an exciting new initiative funded by the UK government with a group called the Oxygen Collab. I hope you've all heard of the Oxygen Collab. We can put a link in the chat, and they're working with UNICEF on a new target product profile for a concentrator specifically designed for low resource settings. So designed to be easy to use, minimal power, alternative power, and something that doesn't break. We haven't talked about graveyards of equipment, but further to Ramanan's comment, we're all very worried that all this oxygen equipment that is now streaming into countries is going to break. and there won't be the biomedical engineers and the clinical engineers there to fix it. So that's another problem we could be creating that we need to get ahead of. And innovation is part of the answer to that, is designing equipment that's less likely to break and can be easily fixed. So yes, there's an exciting initiative around concentrators, but we also need innovation in PSA plant technology and liquid oxygen. And we're hoping that after COVID, there'll be enough groups now engaged in this and enough funders interested that we'll have a proper innovation pipeline with medical oxygen.
Thank you. Thank you very much, Leith. We have another question that is on the last mile issue with delivering oxygen to patients. So zooming into the last mile, do we also need to see and prioritize concerted efforts towards effective oxygen administration to the patient? Going beyond oxygen production and delivery.
Sorry, the question is about
actually being able, like, efforts to prioritize effective oxygen administration to the patient. So once it is in the hospital or once it is in the healthcare facility, I'm assuming.
I think Dr. Bakare should take that question. I mean, this is really a question of how we are able to use the oxygen to save lives. No, I'll take it because I don't know if he's able to hear the question, but this is a concern I've heard in many cases where the capacity or the human resource ability to be able to use oxygen doesn't exist in every place. And so I think, as he had mentioned as well, you need to have the pulse oximetry. You also need to have the clinical expertise, perhaps telemedicine, to be able to make sure that availability of oxygen is translated into lives saved. And that's not something we can really take for granted. But I think an effort to vastly expand the research that we have right now on how oxygen can save lives, in what context it should be used, etc., is really needed. I mean, this is not an area in which we work at all, but I was shocked to see how little research there really is on making the case for or explaining why and how oxygen can save lives. I would say that's a relatively small literature compared to what seems to be the importance of this topic. So, Leith, I don't know if you know more about this than I do, but I've been astonished that we know so little.
About oxygen?
Yeah, just in terms of there is only probably a handful of papers showing the effect of oxygen on childhood mortality, for instance. Don't we need far more research to be able to then also encourage policymakers to make consistent investments in this area?
Oh my goodness, the lack of data on access to oxygen. Really, I remember watching, when the pandemic hit February, March last year, and it was clear to many of us working in oxygen that this would be a disaster because we'd had all Dr. Bakare and his colleagues' papers. We knew what was not in the health system from all that scholarship. So we knew it was a disaster waiting to happen. But watching the international actors scramble for data, it took them months just to understand what hospitals had across Africa, Asia, and Latin America. So a lot of time was lost, precious time, trying to collect data just to understand what countries might need to treat COVID patients. We can't be that blindsided again. So one of the other things we need to do after this pandemic is get the data in shape. There's no reason why the global burden of disease, which is a great data set, can't be creating estimates of hypoxemia-related deaths, for example, cases and deaths by country. There's no reason that can't be part of the GBD, and UNICEF and WHO. There's no reason they can't be tracking pulse oximetry coverage, oxygen coverage for children and adults. We have a massive data collection exercise ahead of us. It's started, but we're going to need to do a whole lot more to answer some of these other questions in the chat. There was a question we missed, an early one from Iftikhar Jilani about What do we know about even what oxygen countries produce and what the need is? Well, we don't know. We don't know. So that is almost like priority number one after we emerge from the immediate crisis.
Thank you, Leith. I think we can address two questions at the same time, and that's about innovative ways for oxygen production. So one of the questions, and I'm sorry I have to scroll up, from Garance Upham, is how about hospitals undertaking oxygen production? Would that be an option since Graham says that I read that industry is selling oxygen very expensively. So this was a report from the Public Citizen. And the very last, one of the second last questions, I think, is also asking on other ways to produce oxygen. So basically other ways apart from centralized production. Sorry, I'm trying to summarize and it's just not working very well. Yes, so
there are more. Yeah, Dr. Bakare, go.
Yeah, let me take the question on hospital undertaking oxygen production. Fine, I think is a good idea, but that does still not make the cost to be affordable, especially for settings like Africa, where we talk about where power supply is poor. Because if you are to do, let's say, construct oxygen plant now, it requires power. And an institution whereby oxygen plant is now being run 24 hours on diesel generators, that still adds to the cost of production. And then also, most of these, let's say like Nigeria now, whereby we need to import virtually everything. Now, things are getting more expensive. And it's something that I'm looking at, perhaps if there can be a movement, because I spoke with one of the suppliers yesterday, and I asked about the price of concentrators. And I found out that it is even quite more expensive now than it was maybe 5 years ago. And I was surprised that I can't afford this, and hospital cannot be able to afford this. And it cited other problems requiring logistics, clearance, and then the issue of demand and supply, how the market forces will react, because there is now increase in global demand for oxygen equipment. So I think from this forum, we also need to look into that, how the company will not seize this opportunity to even increase the cost of oxygen equipment. They're talking about building oxygen plants, but the cost is now skyrocketing, even far beyond what it was before COVID-19. So if hospitals are to be producing oxygen and fine is a way, but it needs to be, we need more oxygen plants than what we have now. In the tertiary health facility I work, we have oxygen plants, but yet it's still not sufficient. It's still not sufficient. And if we have to construct more oxygen plants, now the gas company has increased the price of oxygen equipment. So it's like a dilemma that I feel we may need to look at, maybe humanitarian work to ensure that the price is readily affordable to countries in low and middle income countries. I don't know if Leith has one or two things to add. Thank you.
Just to agree with everything you said about cost, and I'm so glad you raised it. A lot of people, I think, in the North don't understand that during COVID, even before, but during COVID, patients have been asked to pay themselves sometimes hundreds of dollars per oxygen cylinder, which may only last for 24 hours, 48 hours. So yes, there's been an oxygen crisis, and even to the extent there has been oxygen available, families have been asked to find huge sums of money to pay for it because it's not covered. Unlike the COVID vaccines we receive for free. There's a huge system around financing those so that people don't pay. We have not had that level of support for the treatment side of COVID. Patients have been left and hospitals have been left to fund those costs themselves. So I think the cost of oxygen is a huge issue. I agree very much with Dr. Bakare. We have to look at it.
Thank you. Thanks, everybody. We don't have any other questions from the audience. I don't know if you have any closing remarks to conclude today.
Oh, Leith, go ahead.
Okay, just very briefly. So according to the World Health Organization, we're losing 50,000 people every week still from COVID-19. We know it's a massive underestimate. We know it can be 5-10 times higher, the real numbers. But at this stage of the pandemic, more than 18 months in, with vaccines available, not everywhere, but in most places, we are still losing 50,000 people a week, which speaks to the treatment challenge we have. We are still in an oxygen crisis. We don't know what lies ahead with this pandemic. We don't know if there'll be a new variant emerging and the needs could take off again. So we really need to prioritize the need for oxygen and the other treatments that keep COVID patients alive. We are almost at 5 million dead overall, and to keep that number as low as it can be so it doesn't keep rising, we have to keep our eye on oxygen and treatment and make sure when COVID patients turn up and need it, it's there, no matter where they are. We're a long way from that reality, and I'm hoping webinars like this, and I thank Ramanan and the team for hosting us. I hope webinars like this can reach all of you with that message so you can then go into your spheres of influence and argue strongly for investments in oxygen. So thank you.
Thank you very much, Liz.
Dr. Bakare, did you have any final thoughts?
Yeah, just to thank the organizer, for this excellent discussion, and also try to charge everyone to look towards ensuring like a form of a subsidy for oxygen, so that just like what Raman said earlier, that we don't destroy some other functioning part of the system prior to COVID-19. So that is just the only last word from me, to look at how we can subsidize oxygen more, just like what has been done for COVID vaccine. Thank you.
Right. So my own last thoughts, and also respond to Doug Call. I think that we do need to incentivize governments to think about oxygen as a utility, and I think that they are awake to this important need, because the public will simply not permit another oxygen crisis to arise without there being significant consequences and repercussions. And I think states and even the federal government in India is already willing to think about it in these sorts of lines. But the fundamental reason why there is a government role is twofold. One is to make sure that prices are affordable, and second, to make sure that there is rapid movement of oxygen assets from one place to another, and the ability to transport the oxygen. And in that sense, it's much like an insurance policy. A lot of the time, this may not be needed, but just like a fire equipment, investment, this may be needed in times of crisis, and therefore it's important for governments to pay for those assets and maintain them, so that when there is a crisis, you're dousing the fire with oxygen. And that's the way in which to really think about it. But in order to get governments to do it, we need to present them with a clear case of, what the ask is, how we're going to make a system like this work, and third, what it would cost, and how would the whole thing hang together. And unless we really make that happen, today there is not a program for oxygen in most governments. There is a TB program, there's a malaria program, there's a HIV program, there's not an oxygen program. And so the capability doesn't exist in most governments to be able to address oxygen. And I would say that in rich and poor countries. And so we need to use this crisis and turn it into an opportunity to be able to build that capacity, so that there's a lot of potential for health improvement if we have a stable and reliable oxygen supply in the form of a grid. So I think it's really, the responsibility is really on us as people interested in this to make this happen. And I want to thank everyone for coming to this webinar and sharing your thoughts. And do stay tuned for more work that CDEP will do in this area, and of course from our partners at the coalition that Leith leads. And I would strongly recommend, if you're interested in this area, to join her phone calls that she has every other week, which are extremely informative. Leith, maybe you can drop a link on the chat for people to know where to join for your calls. And I found them extremely helpful in terms of understanding and connecting with private sector players working in the area, because this is not going to get solved as just a public sector idea. It's going to require the private sector in a significant and involved way. So thank you.
Thank you, Ramanan. So with that, I'd like to thank, on behalf of everyone who joined us today, I'd like to thank our speakers for the work they do every day to bring attention to this very important issue and address this issue, which it's so well known during the COVID-19 pandemic, but it has been affecting vulnerable groups for years. So thank you very much. As one of the audience members asked about where they could find the link for this webinar, I'm just going to repeat and say that you can find it on our website. I included the link on the chat as well. So thank you very much. And for those of you who have been following us on this conversation series, we have 2 more webinars coming up, and the next one will be on modeling COVID-19 disease transmission studies. So thank you and have a great day.
Thank you. Thanks, Leith.
Bye.
Thanks to you, Erta. Thanks, everyone. Bye-bye.
Bye.
Bye-bye.
Thank you.